Have you ever really thought about the hidden history recorded in your breath? Every time you exhale, you aren't just expelling air. You're actually producing this highly detailed medical fingerprint. Today, in this explainer, we're going to look at how a super simple test of time and volume acts as a window into hidden lung damage. We're going to decode the exact mechanics of how air leaves your body and how that one simple movement reveals some pretty profound truths about your respiratory health.
So imagine taking a really deep breath right now. If I asked you to just breathe that air out normally, you could easily take all day to do it, right? Time isn't really a variable. But imagine forcing that breath out against a ticking clock, pushing it out as hard and as fast as you possibly can. Suddenly, the dynamics change entirely. That shift, going from a leisurely exhale to a rapid, forced maneuver, well, that's exactly how doctors pull back the curtain to reveal functional issues hidden deep in the lungs. It kicks off this fascinating medical detective journey.
Okay, let's dive into this. Here's our roadmap. We're covering the forced vital capacity, the crucial first second, spotting obstructive and restrictive lung diseases, and finally, the ultimate diagnostic ratio.
Section 1. The forced vital capacity.
This baseline test basically acts like an interrogation of the lungs, and the physical process to capture this data is incredibly specific. The patient is asked to perform 3 exact physiological steps. First, you breathe in as fully and completely as you can, expanding those lungs to their absolute limit. Second, you breathe out as fully and completely as you can. But it's really the third step that makes all the difference here. You literally have to do it as quickly as possible. What we're doing is measuring the time it takes for this entirely forced exhalation to occur.
And when we graph this out, we get a curve called the forced vital capacity, or FVC for short. This expiratory profile measures the exact difference between a person's total lung capacity and their residual volume over an extended timescale. Now, the absolute key word here is forced. Because unlike a normal vital capacity measurement, where time doesn't matter, here, time is the critical variable. It's just a much more indicative test of true lung function.
Section 2. The crucial first second.
Zeroing right in on the very start of that forced exhale gives us FEV1. That stands for forced expiratory volume in 1 second. Basically, it tells us exactly what percentage of air is pushed out of the lung at that precise 1 second interval. And as it turns out, the sheer volume of air a patient can physically force out right at this specific 1 second mark. It provides some of the most important diagnostic information in all of respiratory medicine.
There's a golden rule for a normal, healthy lung profile, and it's that most of the air is expired almost immediately. Generally speaking, a healthy person is going to expire 75 to 80% of their total forced vital capacity right there in that initial FEV1 window. Very little is expired after that. So this 75 to 80% figure, that's our healthy baseline to keep in mind.
Let's move to Section 3 and see how this builds. Spotting obstructive lung disease.
Now, when a patient's breathing hits a literal roadblock, it usually involves conditions you're probably pretty familiar with. We're talking about patients suffering from asthma, chronic bronchitis, or emphysema. In these patients, the fundamental problem is an obstruction in the airways themselves, which means their exhale is severely slowed down. When you look at the expiratory volume of an obstructive patient over time, you start noticing 2 incredibly important cues compared to our normal baseline. First, when they go from their total lung capacity all the way down to their residual volume, their overall forced vital capacity, or FVC, is noticeably smaller. But the second element is even more revealing. If you look right at that 1 second mark, their FEV1 just absolutely plummets. It's drastically reduced because they literally cannot force the air out quickly due to the obstruction. And because their FEV1 drops so drastically compared to their already smaller FVC, the mathematical relationship between those 2 numbers completely shifts. Instead of that healthy 75 to 80% we saw earlier, the absolute hallmark sign of an obstructive disease is a massively reduced ratio. We're talking a drop to around 40 or 50%. That dramatically low number, that is the immediate statistical signature of an obstruction.
Section 4. Spotting restrictive lung disease.
Now we're looking at our second suspect category, and here the mechanical failure is entirely different. Unlike obstructive diseases, restrictive diseases are often heavily associated with environmental exposures that physically damage and shrink the patient's total lung capacity over time. We're looking at conditions like asbestosis, silicosis, exposure to coal dust, or even conditions seen in professional bakers due to long-term flour inhalation. These harsh environments fundamentally alter the lung's physical ability to expand.
So, let's contrast these two diseases directly to really grasp the mechanical difference. An obstructive disease means the patient basically can't get the air out fast, but a restrictive disease means the patient fundamentally can't get the air in. Because of this, a restrictive patient's total lung capacity is severely shrunken. Their overall functional tank is just tiny. But here is the totally fascinating part. Their expiratory profile actually has a steeper slope than the obstructive patient.
Now, what's really mathematically fascinating here is that because a restricted patient's total lung capacity is so shrunken, but their actual ability to push air out isn't blocked, their FEV1 is incredibly high relative to their tiny overall FVC. I mean, they expire almost all of their air in that very first second, and as a result, their ratio doesn't just look normal, it actually enhances to around 90%.
Section 5. The ultimate diagnostic ratio. All right, gathering all our functional clues, let's summarize our findings with this rule of 3. It perfectly lays out the 3 distinct fingerprints of lung function based entirely on this one test. So for a normal lung pattern, the FVC is normal, the FEV1 is normal, and that resulting ratio sits right at 75 to 80%. Now for an obstructive pattern, the FVC shrinks, the FEV1 absolutely plummets, and that ratio crashes down to about 40 to 50%. Finally, for a restrictive pattern, the overall capacity is heavily reduced, but the FEV1 remains exceptionally high relative to that tiny capacity, pushing the ratio way up to an enhanced 90%.
And this brilliantly illustrates our core takeaway from the source material today. By stepping back and comparing these markers, the mathematical relationship between time and volume tells the whole story. The FEV1 to FVC ratio doesn't just point out that a problem exists, the resulting percentage specifically distinguishes between obstructive and restrictive diseases in and of themselves. It completely unlocks the diagnosis.
We've seen how everything from chronic bronchitis to coal dust leaves this indelible, totally measurable mark on the simple act of exhaling. So I want to leave you with this final thought. If a single forced breath into a machine can reveal so much about a lung's hidden history and physical limits, what invisible environmental factors are shaping your total lung capacity right now? Think about the air you move every single day. Thanks for joining me for this explainer, and as always, keep asking the big questions.